Okay. Caren? All right, let's give it another minute.
Yeah, I'm getting a phone call from our PSK lead. She's asking for us to help them join in.
Yes, I'm working on it. Sorry, apologies for it.
Don't worry, don't worry. Seems to be a popular topic. Hey, Ashita. Apparently, Emily is not able to join.
Yeah, I just sent her the
And Caren as well.
Yeah, I've informed them.
Okay.
Kiara, are you on that?
I am. I'm trying to get. In the middle. We're getting we're working through it. Apologies. Should be done in a second.
Awesome.
Everything is set.
Awesome. I just see people joining in, so we're waiting for Miss Emily and Caren in a second. Again, everyone, thank you for your patience. We'll give it one more minute and we'll begin.
This one's 987.
Could someone mute them? Emily's here.
Hello.
All right, let's get started. I see that Miss Emily is here, Dr. Joy is here, and Caren is also here. So since we have all our speakers, let's get started. Again, thank you all so much for joining in, for waiting, for your patience. We really appreciate it. So let's take it from the top. Good morning, good afternoon, good evening, everyone, and welcome. I am Ashita Nazareth, a project associate with Med Aditus Foundation. Thank you so much for joining us today for what I know will be an incredible and moving conversation. Today's webinar is titled Living with Sickle Cell Disease in Africa. And over the next hour or so, we will explore this topic from three different perspectives. We will look at it from a clinical reality, we will look at it from the advocacy landscape, and also the most important part, that is the lived experience of those who navigate this condition every single day. But before we begin, a few housekeeping notes. This session will be recorded and will be shared upon request. Please use the Q&A feature throughout to submit your questions. We'll have dedicated time towards the end to get to them. We encourage you to engage. Kiara,
Yes, please, if you can mute yourself.
all right. So we encourage you to engage, to listen deeply, and to start thinking about ways in which you could take action in your own spheres of influence.
Where's Kiara?
All right. Again, we apologize for the technical difficulties. Okay. Yeah. If it's possible, I request everyone to mute themselves, please. I know that Kiara is working on the back end to address it, but we would really appreciate it if you could mute yourselves. Thank you. We also want to take a minute to acknowledge Dr. Rai, who passed away recently, so a minute of silence for them. Great. I now have the privilege of introducing you to our three remarkable panelists. First, we have Miss Emily Gumba. If Miss Emily, you can just wave at the screen so that our audience can see you. Miss Emily Gumba is the CEO of the Sickle Cell Federation of Kenya. She leads the national advocacy and partnerships to improve access to quality care for people living with sickle cell disease. She also works closely with governments, with civil society, and health partners to strengthen policy and health systems. What makes Miss Emily's leadership truly unique is that she brings both professional expertise as well as her own deeply personal experience, as she is a caregiver to her daughter, Caren Gumba, who is also joining us today. So thank you, Miss Emily, for being here. Could you... All right. Next, we have Dr. Joy Muyonga. She is a pediatrician at Jaramogi Odinga Teaching and Referral Hospital in Kisumu. She is also a passionate SED champion. She serves on the scientific committee of the Sickle Cell Federation of Kenya, and she is a board member of the Kenya Pediatric Association, where she contributes to national child policy, advocacy, and care standards. Through her clinical work and leadership, Dr. Joy is deeply committed to improving outcomes for children living with sickle cell disease. Dr. Joy, thank you so much for being here. And finally, we have Caren Gumba. Caren is the founder of Caren Beauty and is a sickle cell warrior herself who believes in building gently but intentionally. Her journey blends with entrepreneurship, with health awareness, and the courage to keep showing up even on the hard days. Her story is one of resilience and hope. Caren, we are so honored to have you with us today. All right. Sheila, great. So let us begin now. I want to start us off with what might seem like a really simple question, but I think it's anything but that. So the million-dollar question is, what is sickle cell disease? Dr. Joy, let me start with you.
Thank you, Ashita. So as you've heard, I'm Dr. Joy Muyonga. I'm a pediatrician at Jaramogi. Thanks for having us, and even thanks for joining this very important meeting. So sickle cell disease is an inherited blood disorder, and it's caused by a mutation in the hemoglobin gene. So usually, instead of producing the normal round red blood cells, the body makes rigid, crescent-shaped cells, and these sickle cells don't carry oxygen sufficiently. So what happens is that they tend to clump together and they block blood vessels, leading to inadequate oxygen supply, inadequate blood supply to the organs. Hence, what we call they get painful crisis, they get organ damage, and also a reduced lifespan of the red blood cells. Normally, these red blood cells have a lifespan of 90 to 120 days, but these ones take less than 20 days and they break down, causing them to have yellowness of the eyes. So, in a nutshell, genetically, it's passed on in an what we call autosomal recessive pattern, meaning a child must inherit the sickle cell gene from both parents to develop the disease. So I don't know if I should dive into the inheritance pattern, Ashita, or do I wait for you?
All right. I think you've just given us a brief clinical picture. We will get back to that because I think that is very important to address. But before that, I would love to hear from you, Caren. When you explain to someone what sickle cell disease is, you've lived with it, how do you describe it to someone who's never heard of it before? I think you're on mute.
Thank you so much. Can you hear me right now?
Yep, perfect.
Okay, I'll explain sickle cell disease to someone who doesn't understand the disease as a red blood cell disorder, that the red cells appear more curved, unlike the normal cells, which are more circular. And at times when you're having a pain crisis, the cells tend to get stuck in the veins, and so you get pains in mostly your joints. This is caused due to
Oh, sorry, you're on mute again.
because of the shape of their cells, and it's not able to carry sufficient oxygen. That's why you tend to have a lot of pain and a lot of you can't breathe really well, having shortness of breath. That I can explain to someone.
That is great. So you just brought these scientific terms, Dr. Joy explained, you brought that into life. Miss Emily, you are not just an advocate, you are a caregiver yourself. How do you explain this to the community? Or let me put it this way, what does the community understand or rather misunderstand about sickle cell disease?
Thank you very much. Many people don't understand sickle cell disease. There's a lot of misconception. Sickle cell has brought a lot of fights amongst family. It has brought a blame game, especially to the mother, because you're told this thing, it's called this thing, you have brought it. When a child is in hospital, the doctors may not even know what's ailing the child. I remember growing up with Caren when Neva should be hospitalized, doctors would be surrounding her, like the students who are practicing, because it's like maybe the first time they're seeing a patient with sickle cell. So to the families, there's a lot of sensitization that needs to go around, that this is a hereditary disease. You get it from both parents or one parent. There has to be awareness that this is something that your child will live with throughout her life, and all you need to do is manage the condition. Many times, parents even hide their children. They think that they've been bewitched. There are a lot of myths around it. There's stigma, especially with the yellow eyes, the swollen stomach, the pain. They can't even express themselves. In schools, also the teachers need to understand, because the pain is so hidden. 1 minute, this child is okay. The next minute, they're in serious pain. Before you know it, there's crisis. Before you know it, there's transfusion. Their life can just be a whole roller coaster in a single moment. So for families, I'll really say there's a lot of work that we need to do, a lot of advocacy for both families to understand that this is a hereditary condition. It's nothing to do with the woman, the man bringing it. No need to blame one another. And for governments and policy makers, we need to see how we can manage, how we can help, how we can support. And lots of trainings need to go on with the healthcare workers so that treatment can be administered very well. Again, you'll realize, for example, in Kenya, we don't have newborn screening, but it's something we have advocated for, and we're really pushing through Sickle Cell Federation of Kenya. We used to have infant screening after 6 months. I know Dr. Joe will talk more about this, but that's where we are at. Once a parent finds out, many of them are lost. They don't know who to turn to, where to go to, and that's where we come in as Sickle Cell Federation of Kenya to raise awareness and to sensitize the public about the condition. Thank you.
Thank you, Miss Emily. You just put it all together properly. It was like that missing puzzle in a missing piece in a puzzle. Dr. Joy, Miss Emily just mentioned that there is a lot of blame game that happens, right? And
Yeah.
most often this falls on the mothers. And she also explained how just the mother's gene is not responsible for the trait, for this condition. How would you explain this from a genetic landscape?
So we have 4 common scenarios that we get that can expose a child to getting sickle cell disease. And I'll give examples. So if you have both parents who are carriers meaning they don't have the disease, but they have a trait, which is HBAS. So if both the mother and the father are carriers with HBAS and HBAS, every single time they get pregnant, every child they give birth to has a 25% chance for getting sickle cell disease, a 50% chance of being a carrier, which is HBAS, and a 25% chance of being unaffected. Okay? If only one parent has sickle cell disease, which is HBSS, and one is unaffected, which is HBAA, we have a 100% chance of their children being carriers. Okay, that is having the trait HBAS. Thirdly, if one parent has the trait, which is HBAS, and one parent is unaffected with normal genes HBAA, the children have a 50% chance of being carriers, okay, having HBAS, and a 50% chance of being unaffected, which is HBAA, which is normal. The last one is that if both parents have sickle cell disease, HBSS and HBSS, it means that 100% of the children, there's a 100% chance that the children will have sickle cell disease. I need to emphasize that it doesn't mean that if your first child has sickle cell disease, the rest will not get it. It is all about chance. So with every single pregnancy you have, those chances suffice and they take role. So some families are unfortunate to have more than one child with sickle cell disease. I know of a family with 6 children with sickle cell disease. So don't think that because one child already has sickle cell disease, that 25% has already gone. It is with every single pregnancy that the chance applies.
So this involves a lot of mathematics, a lot of permutations and combinations. Thank you for giving that picture for us. So would you say early screening is important in that case?
Very important. In fact, we advocate that if we can screen couples when they start dating or before they get married or before they get children, it would be good. And then after that, if they had already gotten married before and they got pregnant, they didn't know their status, it is recommended that we do newborn screening. So currently we do have newborn screening in Kenya, but not as a universal program. It's only happening in Kisumu, thanks to a study by Dr. Wanda called the CONSA study, the Consortium of Newborn Screening in Africa. So it's being done in Jaramogi, Kisumu County Referral Hospital, and Lumumba Hospital. So this is in conjunction with American Society of Hematology, and they've screened over 38,000 newborns. So if we can do newborn screening, we can catch them early and prevent these early mortalities. Of note is that the Ministry of Health has rolled out a policy for infant screening. So this goes up, we want to catch the new infants up to the age of 6 months because most of the time, the children with sickle cell disease present with symptoms at the age of 6 months when their fetal hemoglobin levels have gone down. So they mostly present with joint pains and swelling. So if we can catch them early, we realize that we can prevent these early childhood deaths, which can even go up to the 90% before their 5th birthday.
That does seem very promising and looks like the step in the right direction. So now I want to, now since we have the three lenses, right? We understood what it means clinically, we understood what it means personally, and also from an advocacy standpoint. I want us to zoom out, to take a step back and look at the bigger picture. Ms. Emily, I'll start with you. Why is sickle cell disease such a critical issue in Africa? Like, help us understand the landscape.
Yeah, thank you very much, very much. Sickle cell is among the non-communicable diseases. And for example, in Kenya, in the last 5 years, together with the Ministry of Health, we came up with the guidelines of management and point of care. And with the studies being done, what Dr. Joy is talking about in Kisumu specifically, currently the statistics we have, which could be mind-blogging, and it could be more now that we've started infant screening and newborn screening, the statistics we have, and we are still working on improving on those statistics, is that there are 14,000 children born in Kenya annually. And these are children born concentrated within 23 counties out of the 47 counties we have in Kenya. So that's like half of the region, mostly in the waterborne lake regions, coastal areas. And then the other statistics is that most of them will not live to see their 5th birthday. So with that, it's quite a scare. We don't have really studies or numbers of mortality. I know a lot has been done also to prevent, but with the interventions, government and through our lobbying, government has really, really helped. One is the inclusion of sickle cell disease treatment within our universal health insurance, whereby we are able to get treatment, you're able to get your medication. If you are registered with SHA, what we call Social Health Authority or SHIF, and you're able to be supported. With that, we have seen the mortality rate. Many children are living beyond their 5th birthday. As Joy has mentioned, there's a group, quite a number of people who don't know their status. We also want to work with the youthful people, the young people, to see how we can also help them do screening so that if you know your status, you are able to be prepared to see how you can also start managing the condition. So that's where we are at, but a lot of studies have been done, and we hope to get more statistics and see how we can help many families that are so affected by this condition.
Miss Emily, those numbers are staggering. 14,000 children born with sickle cell in Kenya alone. I mean, that speaks volume. Dr. Joy, Miss Emily also mentioned that most children don't make it past their 5th birthday. Can you help us understand the mortality picture, the prevalence, or anything about the data actually?
Okay, thank you, Ashita. So the earlier statistics that were there about sickle cell disease in Africa was that mortality rates were 50 to 90% of the children would die before their 5th birthday if they were not screened or diagnosed early and managed in time. So this applied to those who have never been screened, not managed, and hence now why we are doing all these efforts for screening at newborn and infant age. So what is important about this screening is that if we catch them early, they start treatment early and they go to the clinics early. Remember, I told you that the commonest time that they present with the symptoms is at around 6 months. So if we can catch them early, it means they're aware, parents are aware of the status, the genotype, they're able to start clinic early, we start giving them preventive medicine. There's a study done by Sophie Muyonga et al. In Kilifi, whereby they found out that of the children that they were reviewing, the mortality rate of the ones who actually were attending clinic regularly was reduced by half compared to those who never attended clinic. And so they were saying that for the participants that they saw, around the mortality rate at that time was 58 per 1,000 person years of observation. And in other studies, it was shown that in many parts of Africa, around 1% of all births are affected by sickle cell disease. And the condition causes 6 to 15% of all deaths in children under 5, just general mortality for children under 5. So we need to know that once we can screen early, we can reduce the mortality by 70%, according to WHO. So you can imagine if we can decrease that mortality by 70%, then why not screen? Why not advocate more? Why not start preventive medicine early? So those are the figures that need to help us to understand why we need to screen. A study that my colleague of mine called Dr. Kuta around 2016, still in Kisumu for newborn screening, showed that the newborns who were screened and who had sickle cell disease were 3.2%, while the ones who were carriers were 13.9%. An earlier study done in Western Kenya by Alwoch et al. Showed that of the people, the highest prevalence was in Western Kenya, which was 4.5%, and a carrier rate of 18%. So if we can compare that to what is happening in the constant study, it's not yet published, but over the 5-year period that they've been doing the study, they have screened over 38,000 newborns, and the sickle cell disease rate of those newborns that they've screened are less than 2%. We believe that probably since 2021, there's more awareness activities and advocacy for sickle cell disease and may contribute to the decreasing numbers of the newborns we are seeing compared to what was earlier found in the western region of Kenya. It has not been proven during the study, but it's just an estimate of what we think may have contributed to the decreasing numbers of the newborns that were found compared to the other studies that were done, which was 3.2% and 4.5% in Western Kenya.
Great. That is fabulous, Dr. Joy. You just gave us a comprehensive, in fact, a data set that we could look at. So what we're seeing is both the devastating scale with, I remember you mentioned 11,000 deaths in 2021 alone, but there's also some hope with these declining death rates due to awareness and advocacy, like you mentioned, and with pushing screening. So I would like to direct my next question to Caren. Caren, when you hear these statistics, all these prevalence numbers, the mortality rates, what goes on through your mind when, all these numbers could just be numbers, but ultimately there are people behind these numbers. These are real, actual people. So how do you hold that with your own experience?
Okay. Ash, the numbers are actually scary, especially 11,000 deaths due to sickle cell. But personally, the statistics has never scared me because I've always lived my life like a normal person. I went to boarding school at a very young age, when I was 12. Um, so I've never thought about the statistics as much, or even think about that when you get to a certain age, you are going to die or something like that. Because at this point right now, I'm a fully grown adult and I've never let sickle cell define who I am. Yeah, so the statistics don't really scare me as a person, but they're really scary the numbers when you think about it.
Thank you, Karen. That is indeed powerful. I remember you mentioned earlier on that everyone's journey is different, and
Yeah,
we just really admire your resilience and hope. So thank you. Now,
yeah.
I would like to go into another section, which I think it'll be better if I, shift gears and direct it again towards you, Karen, because I want to move us into what living with sickle cell disease actually looks like, right, on a day-to-day basis. And you are the most important voice here. You are a warrior yourself, but what most people don't know is that you are a successful entrepreneur in your own field. How do you go about it? Paint us a picture. Walk us through your day in your life of Caren Gumba.
Okay. Like I've mentioned previously, uh, sickle cell has never defined me or who I am. I have lived a normal life. Also, when you tend to understand the type of sickle cell that you have, it will be easy for you to manage your body and yourself. You know your limits and how to push them. So my day-to-day life, just like I was 7 a.m., go to my last day, go to my shop. I have classes from 9 a.m. to like 11, schedule appointments, but I do know my limits. I do know what I need to do. Hydration is very key, to ensure that I hit my targets, which is like 3 liters a day, have a balanced diet, and not to push my body. Some days when I'm feeling low, I don't go to work. When I feel a bit of pain, of course, I'll visit the hospital. I'll see my hematologist. But just like a daily normal life of a person, it has never been, oh, first I'm a sickler, first I'm just a human being. Yeah.
Wonderful. You just reminded me to hydrate myself and drink water. Audience, please keep sipping your water bottles or water. Uh, so you just mentioned the importance of hydration, right? What happens, not just hydration, like everything that you mentioned with taking your tablets or going about your day, what happens if you don't stay on top of that?
What usually happens when you are dehydrated or you just don't follow your routine? First of all, you're going to feel a bit exhausted because remember, your cells are not as normal as a normal person. Um, you're going to get dehydrated, and this one usually leads to hospital visits. You'll need an IV. If your levels are low, of course, you're going to need a transfusion, and your eyes are going to change. They're going to be pale yellow. So you have to remind yourself, like, this is something that you need actually, that for you to survive. And if not, you get to the extreme,
Mm-hmm.
which is hospital visits.
Mm-hmm. Could you
Yeah.
also help us understand what these pain crises look like? I know these are one of the most challenging aspects that you have to deal with as a warrior. And I know that there's several other warriors today on call with us. So everybody's crisis looks different. Could you help us understand your picture?
Okay. For me personally, I don't normally get like the painful pain crisis. Usually, what happens with my body is my blood level usually go a bit down. I can have a HB of 5 and still function without any pain crisis. But if I go to the hospital, they can initially take it as a sign that you need transfusion to boost your blood because they usually say no one can walk around with a HB of 5, but for me, my level is actually at 6. So I don't normally get the pain crisis. When I do get the crisis, I know that's an admission immediately. Any other pain that I usually get is something that I can manage at home. Yeah.
Wonderful. Miss Emily, my question is for you. You are an advocate, but you are also a mother, a caregiver, watching your daughter go through this pain crisis, right? What is that like for you? I know that you have to balance your own fears and worries, but at the same time, you need to tend to your child.
As a mother, as a parent or caregiver, it's one of the worst anything you go through because your life stops. You have to focus on them. And just remember, I said it does not call. 1 minute they're okay, the next minute you're either rushing to hospital, the pain has increased. She just did mention as a child, I used to tell her, don't do this, don't, like they're not normal. They'll go swimming. At night, you're in the hospital with her. They want to play football. Before you even know it, something is wrong with her. So, as parents, we are always worried, we are always concerned. But one thing I learned with Caren, her resilience, she's a very strong girl. She went even to boarding school when she was about the age of 12, 13. She's been very independent. And it's because I allowed her to be herself. I've allowed her to understand what her body, when her body is not right, she knows what she's supposed to do. When, there's what she can manage, but when she knows things are really out of hand, then of course we have to rush and see a doctor or even go to a hospital, and we know what will be next. You are put on a drip, Maybe if the HB is very low, of course, she also has to get transfusion, and she has to take her medicine every day, hydroxyurea, folic acid. At least we don't take Poldrin anymore. And if there's anything any parent dread, it's the cost of buying hydroxyurea in Kenya. This is some of the things we're advocating for. And you can imagine there are families that have more than one child with sickle cell, and you have to buy hydroxyurea almost $1. You have not factored in other things they may need, supplements, she talked of special diet, dehydration. So the cost of caring for a child, the cost of even going to the hospital that will be able to handle their situation is really a burden to many families in Kenya. So there's a lot that we're advocating for so that the burden can be eased of the parents, so that the point of care, the medicine.
All right. I think Miss Emily is frozen, but just to summarize it, she was talking about this constant state of being ready all the time. I can only imagine how exhausting that must be, but also with the financial burden that one has to deal with. Dr. Joy, could you help us understand why hydroxyurea is so important, or in general, the treatment options that Ms. Emily mentioned about hydroxyurea, folic acid, or other antibiotics? And Karen also brought up the fact that blood transfusions are equally important. Could you help us understand what an ideal care plan for sickle cell looks like? You're on mute, Dr. Joy.
I was so focused, I forgot. Sorry, thank you for that
No
reminder.
worries.
Sorry. So an ideal care plan for sickle cell disease for me as a doctor to the warriors would be that we have adequate healthcare financing to start with. We need to budget for sickle cell disease. I'm grateful to the government, the Ministry of Health, that they actually put a package for the warriors. And at least now it's covered under the universal health coverage. So the first thing I would advocate for a comprehensive coverage for sickle cell disease would be that we have universal newborn screening. So if we miss them at the newborn stage, the infant screening should continue just before the age of 6 months, so that we can catch them early and start them on prophylactic treatment. So at birth, when we test them, we usually give them the penicillin V. This is an antibiotic which is given twice a day to prevent acute chest syndrome. That's an infection that's like pneumonia, a severe one that affects people with sickle cell disease. And then we also give them proguanil in malaria endemic areas to prevent malaria. Thirdly, we give them folic acid, depending on their age and weight-based. So usually all these are given, and we also advocate that they get their regular vaccines as per their age and schedule in the Kenyan DVI schedule. After the age of 5 years, we recommend that they get the pneumococcal vaccine. So if they're okay, they don't have recurrent acute chest syndromes, they're okay, they're stable, we stop the penicillin V, we give them the pneumococcal vaccine, and they continue with the other medication. So at the age of 9 months, we recommend that we do a confirmatory test. The fetal hemoglobin levels keep reducing with age. And the fetal hemoglobin is usually very good for them because it helps them to prevent more sickling of their cells. But now as they grow older, the fetal hemoglobin reduces in quantity. And that's why by the age of 9 months, we want to do a confirmatory test to be sure that they actually, we know their confirmatory status of their HbS levels and how many, the percentage of HbF that they have. So we begin hydroxyurea at the age of 9 months. Sometimes once in a while, we are advised to start earlier if a child presents before the age of 9 months and they present with recurrent crisis and there are too many to manage at that stage. We are actually allowed to start with hydroxyurea before the age of 9 months, but generally 9 months is the cutoff for our patients. So once they're on hydroxyurea, they continue on that, and this is weight-based, and we keep adjusting it according to the weight, the age, and also the hemogram findings that we get for these patients. The other thing that we advocate for these patients is that if we can get blood transfusion services for them. I'm glad to note that our facility, Victoria Annex Hospital, is the first public hospital in Kenya to offer automated red blood exchange transfusion. our warriors, who, especially the ones who get recurrent crises, more than 5 in a year, acute chest syndrome, stroke, priapism, and such like complications that are so severe that we want to give them this transfusion to prevent further complications and recurrence. The other thing we advocate for to be part of this program is that these clinics, patients should attend regular clinics, and a minimum of at least, if you can do at least every 3 months, or if sometimes monthly, depending on how the patient is presenting, but 3 months is the least we can do. And with these clinics, we advocate that they can have at least a hemogram done and a blood smear for malaria parasite for the ones which are lower level facilities. For higher level facilities, they can do kidney function and liver function tests with reticulocyte count. But otherwise, a hemogram and a malaria test minimum should be good enough for at least follow-up to check on the hydroxyurea, how they're responding. So another thing that we advocate for is transcranial Doppler ultrasound of children between the age of 2 years to 16 years, so that we can actually rule out the risk of stroke, screening them for the risk of stroke. Another thing that may not be done adequately that we are advocating for as a comprehensive care for our patients is transition services for our adolescents.
You're on mute.
I've been muted again. So am I okay now?
Yeah, you're good. Yeah.
So another thing we advocate for is transition services for our patients who are adolescents. Somehow they end up getting lost in the system.
Mm-hmm.
So unfortunately in Kenya, when you reach the age of 13, you're told to go to adult clinics. I don't know when it started. It's not a government policy, but it's being done across board. So you can imagine you're 13, you're tiny, you have sickle cell disease, probably you're small for age. So you go to the adult clinic, you look lost. Then in the pediatric clinic also, you don't fit in. So if we can get the transition services fit for adolescents and young people, we actually will get better attendance of clinics for this age group. Another thing is that we miss out on psychosocial support. We need to give psychosocial support for our patients, our caregivers, and play therapy for children. Children need to play. So a happy child with no pain will play. There's an example of a mother who told me the child, when she didn't find me in clinic, she was like, I want the doctor for coloring. Because I used to give them crayons to color and books to color. So things that we don't think about but are important to them, have a place where they can have support, like a support group interaction. Psychosocial support for them is good. Second last, specialized pain management. We need to know how to manage their pain. If we don't know how to manage their pain by first noticing that they're in pain, trusting that they're in pain and they know how much the pain is, and giving them the right medication at the right time, we will not get that right. Lastly, all these parents, you've had Emily telling you that she's always been like a girl guide. She's always prepared for anything. When she sees a phone call from Caren, she knows it could be something, it could be a crisis. So you can imagine there are some parents who they spend their lives in hospital. According to some studies done earlier, I forget the team that did it, they were saying that some people get 5 to 6 admissions in a year. 5 to 6 admissions in a year. So it means you're spending every quarter maybe in the hospital. So these parents are there with you. Maybe a caregiver is there with the patient, and they're not able to fend for themselves financially. So I would advocate that even as we do all these things, we find ways to empower economically our caregivers and our adult warriors, so that even as they go through crisis and they go through the disease, they are not disadvantaged on that front. So to me, a holistic package to manage our patients is what can make our country a better place and the world a better place for them, because at the end of the day, they're part of us. They help the economy to move forward like Caren is doing. And if we don't support them, then we are not working well towards ending the crisis.
Absolutely. You put that all together so well. I'm just still trying to digest the information that you gave. You started off with early screening, the importance of diagnosis, trying to understand your status, whether you have it or not. But you also gave us a lot of information about the drugs that you're supposed to take, the right drug at the right time. I'm biased as a clinical pharmacist, so I have to bring in the drug component. So you gave us a wonderful picture there. And also with respect to psychosocial development, I think it's very important to understand that it's easier for adolescents to get lost from the transition from being a child to being an adult. And again, I would imagine that the pain medications that they take would be in varying dosage or doses, or probably they need a new drug altogether. So thank you for giving that picture. Miss Emily, I'll hear from you now. this is what the ideal care looks like, right? Could you help us understand the gaps? Like, what does it look like in real? Yeah, you spoke about, Dr. Joy spoke about a comprehensive care plan, like they need transfusion. She spoke about availability of these, accessibility of these. But could you help us understand, say, the financial side or the systemic barriers that come into play?
Sorry, Ash. Sorry, just repeat. I got a bit of disruption.
No worries. So I was
Yeah.
asking you if you could help us understand what the reality looks like. We just understood the comprehensive, the holistic care plan that Dr. Joy gave us, but I can imagine that it's far from reality if the numbers are so high, right? So can you help us understand the gaps, the systemic barriers, whether it's getting to the hospital, the transportation problem? I know there's so many things that can come into play. If you could explain
Yeah.
that to us.
Yeah. So one, just as I said, this is a lifelong condition, and you have to take your medicine every day to avoid the crisis. So that already is a huge financial burden on the parents. Two, you have to ensure their a balanced diet. They're very picky, also what they like eating. It's not like what everybody else likes to eat. And to any normal parent, you have to struggle in between knowing what also to prepare. There are all this nutritional advice we get. And then, as Joy has put it rightly, psychosocial issues. When this child is sick, you're also sick. When she's having the pain, when she's not sleeping, you're also not sleeping. And the following day, you're also expected either to go to work, to go about your normal duties. Your other children are also looking for your attention. Everybody's looking up to you to offer that support. Really, we need that holistic way of managing the condition. So sometimes you also go to the hospital. There are clinic days, but sickle cell does not know clinic days. I like what Dr. Joy was saying, that you have to go to hospital regularly. But sometimes the crisis can, and the doctor is not there. And maybe you get a doctor who does not understand. So by the time you get the attention, and this is a reality, a doctor who understands that maybe I need to put this child on IV, I need to give a pain, whatever, I need to give this kind of antibiotic. I need, like 12 hours has gone without you getting treatment. And sometimes lives have been lost because they did not get the right attention at the right time, simply because also the medical personnel who was there did not understand or know how to manage the patient. That is a sad reality. And one of the things we are pushing for is training of the health workers to understand how to manage right from the level, the lowest where they can reach, right from the main point of treatment. You don't have to go to a referral hospital to see a specialist. If I'm able to walk to a government hospital, will this doctor understand I'm in painful crisis? Then this is how to manage first my pain, then treat me for whatever the chest condition, because sometimes it will be the chest that is so congested, you're having this pain. So that immediate care is what we need. And it's something we're really pushing for, because many of the lives that have been lost is simply because there was no immediate attention. That doctor who handles them was not in place or was not there, and they did not just get the help they needed. It's a desperate situation for many parents. And there's a lot of fear that how do I manage every day? And I can tell you for fact, for Caren to be where she is, she's a very strong girl. She's gone through all the pain. She's gone through all until she doesn't feel like it's pain anymore. So I really think if we continue working the way you are saying, bring everyone involved, let medicine be available and affordable for many of the families, we are going to save many lives. Let also get nutritionists to also help them manage how do I, within the environment I come from, what are the alternatives if I don't get the supplements to help also boost my blood? Because not all the time, oh, I forgot. getting blood is also not a guarantee. You can imagine, as Caren said, your HB level is at 5. The doctor says you can't go home. The next time you get transfused is after 48 hours or more than 24 hours. So blood is also another situation that we need immediate and quick support with. Thank you.
Thank you so much, Miss Emily. Again, you painted a wonderful picture. You told us about the realities, but also the importance of the treatment options and blood transfusion and everything. So, thank you for giving that to us. I see that we're almost at the top of the hour, but here I want to pause for a second and direct again my question to Dr. Joy and Miss Emily. You are both caregivers in your own capacity. You given so much clinically, emotionally, physically. What do you do to take care of yourselves? Like, how do you fill your own cup? Dr. Joy, do you want to start us off?
Okay, thanks, Ashita. So I sometimes when I've had a bad day, I go home and I debrief with my
Mm-hmm,
spouse,
mm-hmm,
sometimes my friends. Most times I pray about it
mm-hmm.
and then I tell God, I tell him all the things I want to tell him. I tell my husband, of course, sometimes he's my punching bag when it comes to my stress. And then I dance. I told you
Oh,
I dance Zumba. I dance Zumba with my boys and we just move around the house and we just dance, not for exercise, just for fun.
mm-hmm,
When I can't do that, I go to the garden, I do some gardening.
mm-hmm,
If that is not enough, I change environment. I go, I travel. I learned that when you think something is normal in your environment, it's not the same in another environment. So I travel, I get to see what other people are going through,
mm-hmm,
either in sickle cell world or just normally in the world. I just travel for fun and sometimes for work and sometimes to learn. So
mm-hmm,
for me, I change environment. I do self-help, it's called self-care.
mm-hmm.
And the most important thing that I do, I sleep. I sleep for long. If I can get 12 hours of sleep when I'm stressed, I'm happy. So yeah, that's what I do and many other things, but those are the most important ones that I do. Yeah.
Mm-hmm. Wonderful, Dr. Joy. Miss Emily?
Hmm. Dr. Joy has picked some of the things I do, but for me, it's reflection. Sometimes you just want to have that your me time to take a lot of reflections.
Mm-hmm,
Prayers help.
mm-hmm,
Sometimes those who appear to be strong on
mm-hmm,
the outside
mm-hmm,
are so weak in the inside.
mm-hmm,
So you need to really encourage yourself. So you need to have a moment to take care of yourself emotionally. Then, as Joy has mentioned, you need also people around you. I
mm-hmm,
have a very strong support system. Anytime I even just post on social media or they call me and they're like, are you okay? Are you yourself? You say, no, Caren is in hospital. You say no more. And they're there and they already surround you with love. And that really helps. Even when you are looking for people to donate blood, I've never taken more than 24 hours.
mm-hmm,
Volunteers, a friend will call a friend and we get people to get blood for Caren. So
mm-hmm,
having a strong social network helps. You reach out. Of music is very therapeutic. You add
mm-hmm,
with prayers, you add with the love of family, and just having people around you is what gives us the momentum. And Caren knows we have the mommy daughter time when we are like, hey, I haven't seen you for a whole month, I haven't seen you for a week. Can we have our own time and maybe have a brunch, do some activities together? We love traveling, both of us. They're always traveling, but it's a way of also getting yourself out of that situation. Also, just a lot of things because you have to balance work, you also have to balance your personal life. So it's a very delicate way of managing that.
mm-hmm.
So
Thank you
thank
so
you.
much, Miss Emily and Dr. Joy, both of you. You just shared the importance of community, of faith, of replenishing ourselves before we can pour into another cup. Thank you again. Before we get into the Q&A session, which I know should be starting any time now, I want to end this on a say you could give everyone, all our audience members, a takeaway message, right? What would that be? Caren, what sustains you, what keeps you motivated, or anything that you want our audience to leave with.
All right, Ash, the question is a takeaway or an encouragement.
Yeah, anything that you'd like.
Don't let sickle cell define who you are. You have to choose what you feed your mind and
Mm-hmm.
what you feed into your soul. So make sure that you live life to the fullest. Go out there, um, visit family, visit your friends,
Mm-hmm.
and just live a normal life, like a daily life. Go to the club, but also you should know your limits and don't push it too hard because there's a lot to be seen out there rather than seeing hospital ceilings
Mm-hmm.
and IVs and injections. There's a lot you can do outside. Make sure you do what you love. If it's dancing, if it's singing, if it's cooking, just live your life. Don't let it define who you are. And don't take it as a disability. As long as you take your medication, your water intake, you do your monthly visit to the hematologist just to see where you are, you'll
Mm-hmm.
be totally all right. That's
Mm-hmm.
my takeaway.
Thank you, Karen. You just highlighted the importance of listening to your body to be more intentional. Thank you. Like I can see in the comments already, everybody is praising you. You are a warrior. You are a very strong warrior. So thank you. Dr. Joy, any last words? You're on mute.
Again, I forget. Thank you, Ashita. So, two things. One, a religious one. The Bible says in Jeremiah 29:11, God has good plans for us. So I want to tell all the warriors there is hope.
Mhm,
God has good plans, and you can be sure for as long as some of us are alive and are kicking, we shall push for the agenda of sickle cell, and we shall push for better services for all of you across the globe, and we hope that our efforts will count. So keep having hope and keep hope alive. The last one, my favorite author. Allow me to just read this. This is
mhm,
Maya Angelou.
mhm,
So do the best you can until you know better. Then when you know better, do better. This is to the caregivers and the healthcare workers. Some of us may forget what sickle cell is about because we don't see them a lot. We don't see a lot of patients with sickle cell, and we get knowledge decay. We forget many things. So if you forget, go back, encourage yourself, learn something new, read something on it. And if you don't, go get some training, attend CMEs, get more knowledge so that when you know how to manage sickle cell patients better, you will do better for the warriors. We
mhm.
all are here to make the lives of patients better, and I wish us all the best. Thank you.
All right. Thank you so much, Dr. Joy. You just said hope. Hope is one of my favorite words. So thank you. This does make us feel hopeful. And Miss Emily, you get the last word.
My last word to the caregivers, you are not alone. Look for a support group.
Mm-hmm.
Share your story. You'll find that yours is not even half of what somebody is going through. I always see despair.
Mm-hmm.
Let us turn this disease into an opportunity to share successes, positivity. If you
Mm-hmm.
meet Caren, you wouldn't know that Caren is a warrior. She's just a normal girl going about her life and living her life. I would say, and I'm looking at being the CEO now, is how can we move the sickle cell disease from being a rare disease people whisper? We
Mm-hmm.
should not be whispering about sickle cell
Mm-hmm.
because people need to know. We need it to be recognized as a public health priority with strong preventions and education strategies. And to my warriors, my fellow parents, my fellow caregivers, and also people like Dr. Joy, people in the health fraternity. I know many of them are also in the call. This prayer gives me comfort. We call it the serenity prayer. And we say, God, grant me the serenity to accept the things I cannot change, the
Mm-hmm.
courage to change the things I can, and the wisdom to know the difference. So I leave you with that, just the serenity prayer that God can keep on and granting us that serenity.
Absolutely beautiful. Thank you. Thank you, Miss Emily.
Positivity. Yeah.
Yeah, we needed to end that thing on a positive note. So thank you once again. Uh, I know that we're already at time, but we will have a Q&A session for the next 5 minutes. You could either drop it in the chat box and I will moderate it and ask questions, or if you want to unmute yourself and ask our expert panelists, you could also do that. So please raise your hand and we will go one by one. Okay. Oh, okay. We have Anvita Nazareth. Please go ahead.
Okay, hello everyone. I have a question for Miss Emily. As you mentioned earlier about stigmas people have about sickle cell diseases, I want to emphasize more about children having the yellow eyes, as you said. I want to ask, is there a particular label or a myth attached to the disease that makes families hesitate to seek help until it's too late?
Miss Emily, Anvita happens to be my sister, so go ahead.
So part of the stigma or why they don't want to seek help is they imagine this child has been bewitched, because why are you not leading a normal life? I mean, why aren't your eyes clear? And they start looking for who is doing something to you or to your body. So it's about awareness, just as we mentioned, sensitizing them and educating them first to even know that those are some of the signs, the jaundice, or even the skin turning yellow, and the pain. You cannot explain that pain. So if you're not well guided or well, you don't know what to do. So the stigma is your yellow eyes is maybe, I don't know how to say it, but people just saying maybe there's bewitchment, or maybe there's just something not right with you as a child. And with a small baby, you have a swollen stomach. They just wonder, why are you different? Actually, they think you're different from the rest of the other kids. And yes, they do look a little bit different. Thank you. And then, of course, there's a lot of discrimination. Even the teachers don't even know what to do, how to handle them, because 1 minute they're okay, the next minute they're even missing a whole exam. And then they say, oh, you're just pretending, because it's an inner pain. Thank you.
Thank you, Miss Emily. Dr. Joy, I keep seeing this one question being repeated several times. What is the relationship between malaria and sickle cell disease?
So sickle cell disease is prevalent along the malaria belt. I think it is thought that sickle cell disease it was a form of mutation that happened to our bodies to protect us from severe malaria. So I think people who were in this malaria belt had maybe initially, this is my understanding, that they became carriers. Some of them, the mutation now, they had this carrier gene and everything. And then, of course, when there's intermarriage and everything, and then we produce children with sickle cell disease. But I think it happened because the red blood cells were actually being attacked by the malaria parasite, so much so that then the body had to mutate to protect us from the malaria parasite. And so when you're a carrier, actually, they don't get severe forms of malaria. So I think that was a form of the body mutate, the genes mutating to protect us from the severe forms of malaria. And hence why you see very many people with traits do not get severe forms of malaria or malaria at all. So unfortunately, maybe we didn't know as human beings, and we ended up marrying each other, those who have the trait, and of course, hence we get now the children with sickle cell disease. So that's my summarized version of it.
Thank you,
Yeah.
Dr. Joy.
Yeah.
Caren, I'll probably direct the next question towards you. Somebody said that the misconception, like a child is born with sickle cell disease, dies very young. Do you have a message for people who believe that, folks with sickle cell die very young, but you are a living example who's done it gracefully, beautifully, and courageously? What would you like to say to that?
Uh, That's a myth. Seen someone in the comments, Tunde, he said that he's 60 and is a sickle cell warrior. And like, wow, so you can take an example from Tunde because he's 60, I'm 32, and we're all doing really fine. Uh, don't let those words get inside your head. Because when I grew up, um, when I was growing up, they had mentioned that you won't get to your 18th birthday. It was scary, but years came. Now I'm 32, doing really well. So that's a myth. Yeah.
Thank you, Caren, and to all our warriors listening in and tuning in. We see you, we encourage you, we support you wholeheartedly. So thank you. And somebody said that they're over 60 years and going strong as a warrior. So all I want to say is we are celebrating you. I think we will take one last question before we wrap it up. I see that we're already past time. One last question. Anybody? All right.
Oh, hello.
Yes, we can hear you. Do you have a specific
Can
question
you?
that you'd
Okay.
like to target?
Okay. Good evening to you all. My name is Oluwatosi, calling from Nigeria. I would
Hello.
like to ask a question regarding. Yes, thank you. I would like to ask a question regarding the transitioning from teenagers to adulthood in Kenya. Can you share more light on that, please, for sickle cell warriors?
Of course. Caren, do you want to start us off first? Could you explain your transition? And then we could turn it to Dr. Joy or Miss Emily, whoever wants to take a stab at it.
My transition from teenage to an adult.
Yep.
That was a bit confusing because as a sickler, you usually have a small body, like you can be over age, but some might think you are a child. So when I grew up, I wasn't developing into a woman, and I actually thought something was wrong with me until later in life, like when I was 20, that's when I started developing like my lady parts. So of course, because I don't know, I can't understand. I don't actually understand how we get to be so tiny, how our faces are usually glowy. Even when you see someone like my auntie, she's 45, she has just turned 25, and she doesn't look an age over 30. So I don't really understand that. But I wish maybe Joy can elaborate. Maybe it's something in the genes. I don't know.
Not even that. Let me just add before Joy comes. Part of the transitions, and I think this is Olu's question, like Caren, do you change even doctors? Because you see, as she's mentioned of her body frame, for a long time, I don't think in Kenya we are able to take care of the young adults with sickle cell. There's a gap there. And I think Dr. J can also shed some light into that. So they'll still be going to the pediatrician doctors to support them. But that's an opportunity that we need to see. How do you transition them from being children to young adults? Yes. And if we have doctors, treatment, because even hydroxyurea is given according to your weight, as you progress. So still there are many opportunities and there's a gap in that area.
Yeah.
Dr. Joy?
So yes.
Yeah.
So thank you for that question. Yes, there is a big gap, and if you remember, I mentioned about transition. It's a big problem. There's a friend of mine, 2-3 friends of mine used to come to my clinic or at the wards, in the wards, in pediatric wards, and say, I'm in crisis, give me fluids first before I go to adult ward. It's like they don't understand them or something, I don't know. But they say, we prefer pediatricians anytime. I would tell them, please go to the adult side. No, you give me here first, and still I stabilize when I go. And those are 30-something year olds. So apparently they said, maybe not putting our own horns, but they said pediatricians will understand them because we've been with them for so long.
Absolutely.
I don't know why there is a disconnect, but one thing I know is that the sickle cell warriors who are adolescents and young people, they're too big for the pediatric clinic, and they're too small for the adult clinic. So that in between is where we have a big gap.
Correct.
And what I've realized, they are comfortable with, they like seeing the familiar faces. So if they see somebody else that is not a familiar face, they get discouraged. So what we do in our clinic, we keep the same faces most of the time if we can. So even if it's adult clinic and pediatric on a different day, they come and see the same familiar faces that they've been seeing. So hence why we really pushed for having Victoria Annex Hospital to have the same team taking care of the same population. So they see this nurse, they see that clerk, they see that doctor, they're familiar with them and they're comfortable. So the only difference comes in now that as pediatricians, we see them, ideally we should be seeing them up to 18, but because of our current situation in the country, we haven't yet had services for them up to the age of 18. So at the age of 14, they go to the adult side. So we start talking to them about it and encouraging them that the other side is also good. And it's the same team that is taking care of you because you have medical officers who see both kids and adults. So the difference may be the consultant. But the nurses, the clinical officers, the medical officers are just the same. So we are trying to find an environment for them that they will be comfortable having, and they will not feel like they're being thrown to the other side. Initially, it was bad on the other side because on the main hospital, our clinics were separate. So one was in the pediatric unit, and the adult clinics were on the opposite side of the hospital. So there was not one unit for them. But now we are coming up, God willing, with a center of excellence that will be taking care of sickle cell warriors only and with other hematological conditions. And to us, that would be a game changer because they'll be seeing the same familiar faces and we can tailor make it to what they need. And God willing, have a transition clinic specifically for adolescents and young people, and we'll train and capacity build our staff to be able to manage these cases better.
Okay. Thank you, Dr. Joy. Thank you so much once again. I know that we're getting a lot of questions, but unfortunately, we will not be able to get to all of those. Please do not hesitate to reach out to us. You could email us, you could write directly, you could contact us on LinkedIn. We have our social media presence, so feel free to direct your questions that way. I also want to thank you again, our incredible panelists, Dr. Joy, Miss Emily, and Caren, for sharing your expertise, your experience, and your hearts out with us today. Thank you so much. Really appreciate it, Asante Sana. And to everyone in our audience, thank you for being here. If today's conversation moved you, I encourage you to take action, whether it is supporting an organization like the Sickle Cell Federation of Kenya, or advocating for policy changes, or getting screened early just to know your status, or if not for anything, just to simply spread awareness in your communities, so be it. But again, thank you all for being here, for learning, for caring enough about this. Sickle cell disease affects so many people globally, and the more we learn about it, the more we understand it, the more we can do about it. So thank you. Asante Sana, Sayonara, Namaste, and here's me signing off.
Karibu, karibu.
Thank
Asante, good
Karibu.
night. Good
Asante.
night.
Good night.
Karibu,
Good night,
Good
asante.
everyone.
night.
Bye. Good
Thank you
night,
very much,
everyone.
Thank you.
Thank you.
everyone.
And
Thank you.
thank you
Good
for
job.
our audience. Our
Thank you,
audience, we
audience.
really thank you. Thank you. Yeah, thank you.